I'm just going to do these real quick because we're going to talk about them more in class. The left to right shunts that we talked a little bit about yesterday with Eisenmenger. Left to right shunts are simple and they go from high to low pressure. And the pressure's higher on the left side. Left atrium is higher than the right atrium. Left ventricle is higher than the left ventricle, obviously. Left ventricle is higher than the right one by 120 versus 30. So you get 4 times the pressure. That's why if you have a hole in the ventricular septum, whoop, it's going over into the right ventricle. If you have a hole in the atrial septum, it's going from left to right. And the other one is the patent ductus arteriosus, the PDA. And the ductus arteriosus is part of the fetal circulation, remember? Mm-hmm. And it's right after the left subclavian, and it goes from the pulmonary artery to the aorta, right after the left subclavian. That thing's supposed to be done closing by about 3 months. As soon as you come out kicking and screaming, that thing starts to close. But it doesn't close in some people. If it doesn't close, in the fetus, it shunts placentally oxygenated blood from the lungs into the descending thoracic aorta, into the abdomen and lower extremity, doesn't it? Mm-hmm. Right after birth, though, the pressure goes up in the aorta. So what have you still got? You got 120 in the aorta, you've got 30 in the pulmonary artery. So if the ductus arteriosus doesn't close, it is an external aorta to pulmonary artery shunt. Agreed? So what are all left to right shunts doing? That's why the left to right shunts were in the pulmonary arterial hypertension discussion yesterday. Because all left to right shunts are pumping blood back over to the right side of the heart, either in the heart, ASD, VSD, or external to the heart, ductus arteriosus, aorta to pulmonary artery. They're all overloading the pulmonary circulation. And they will also increase the chamber pressure, workload, and enlargement. Because when you have an increase in volume, it increases the workload because the chamber's got to pump harder trying to move that extra volume of blood. So when you have increased volume, you get increased pressure, increased workload, and chamber enlargement. So all left to right shunts overload the pulmonary circulation. Right to left shunts do the opposite. But right to left shunts are more complex. The cyanotic shunts, and we'll talk about them next week. There's actually 10 cyanotic shunts that we'll mention. 10, right? Well, 5 of them cause 80% of all cyanotic heart disease. The other 5 cause most of the remaining 20%, and 3 of them are left to right shunts with Eisenmenger. You know, ASD with Eisenmenger goes right to left. VSD with Eisenmenger goes right to left. It starts out left to right, it goes right to left eventually. Okay? Okay. So I'm not even going to bother with these because we're going to talk about this in lecture. But right to left shunts are 1 cyanotic and 2 complex. Why would they be complex?
Because you're not getting any oxygenated blood to the rest of the body.
No, that's what the result is. How are you going to push blood from a low to a high? How are you going to do it? You can't do it with a simple shunt. A VSD is left to right, not right to left. How are you going to make it right to left? A VSD is part of tetralogy of flow. You have to have something else that changes the pressure gradient. That's why cyanotic right to left shunts are complex shunts. And what they do is they steal blood from the lungs and run it back over into the systemic circulation. Like tetralogy of flow, trilogy of flow, transposition of the great vessels, truncus arteriosus, tricuspid atresia, pentalogy of flow, Epstein's anomaly with ASD. Those are all things we'll talk about. Right to lefts are complex. Left to rights are simple. You just put a defect in, blood goes high to low. To push it uphill, that takes a little bit more complexity to do that. Okay? We just have a couple